Hi everyone, I'm Dr. Faisel Sayed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care. Today, we're talking to Dr. Wendy Barr from UMass Chan-Lahey Medical School about From Classroom to Clinic, Leadership in Healthcare Innovation. Let's get started.
Oh, Dr. Dan, it's good to see you.
Good seeing you, Faisel.
And Dr. Barr, my goodness, we haven't seen you for a long time. It's good to see you again.
It's good to see you guys as well. Have you guys been having a good summer?
It has been an adventurous summer, that's for sure. I've been meeting with a lot of family, talking with a lot of friends, and we talk about the challenges of, what it takes to become a board certified primary care doctor in America. And many people don't know that most of the training that we spent was in the hospital settings. And it really wasn't until Dr. Dan and I started going around giving lectures about value-based care and, how to overcome resistant patients or people who are flippant maybe, so far as prevention is concerned. And when I think about it, the way we were trained in hospital-based settings. There wasn't really that incentive there about how to overcome. It's kind of take it or leave it sort of style of training. And I was trained on an unopposed program. We got to deliver the babies. We did all the emergency room and all that. But I think it's becoming more clear now, especially over the last 10 years with the development of value-based care and all these programs moving towards value-based care where there's an incentive to influence positive behavior changes. I wanted to start off, we always start off with a question. And the question I had for you today is that, the way that we were trained in the past to enter the primary care workforce, it may have worked for a time when doctors were working in they're working in the hospital, they're working in the outpatient setting. But now where you have the vast majority of students are working if they're going to go work into the outpatient setting, it's very rare that you'll find doctors admitting patients in the hospital and then running back and forth to the hospital, the clinic. In your opinion, Dr. Barr, what are some of the key components that the training with the primary care workforce of today, what are some of the key components that need to be changed?
Yeah, thank you. And thank you for letting me talk about this. And, I know we've talked about this in some settings at Society of Teachers of Family Medicine and Family Medicine Education Conference. And I think really, as you said, healthcare has changed. Healthcare has changed. We have all changed. What we're willing to do for work has changed as well. And the institutions that we work with has changed. So there's so many things that have changed. And you're right. We're still thinking we're going to train people the exact same way we trained them, 20, 30 years ago when healthcare systems were smaller. People worked in a different way, and what our patients needed was different, right? And what we're finding is it doesn't work. And we know that mortality is going up. We're not getting the outcomes that we want. So thinking differently about the future, I think there are some really basic things we need to think about. And one of the things evidence is showing us is that training people out in the community really improves people's ability to be able to deliver good, high quality primary care. But we really need to think about what does community mean? I think we often think about teaching health centers, and I spent most of my career in teaching health centers, was trained in one before they even had a name in them, trained before there was teaching health centers, but in a federally qualified community health center. But I do think community hospitals and community practices can do this. Direct primary care could do this. I've had these thoughts of what would it look like to have, a residency practice that was a direct primary care, and different primary care innovators, practice clinics, private clinics. How does all of that? It's an and not an or. And I think we need to think really broadly when we talk about community-based training. It really is about all the different ways outside, as you said, the four walls of a hospital. Do you train and see patients where they're at? And so maybe that's even, in home-based care programs. But I think thinking about that in a broad way, the challenge is those institutions don't have some of the infrastructure that you need to provide high-quality education, particularly as we've learned how to better educate physicians. So that would be the other piece that we have to figure out how to do. We have to get the educators and the community-based programs and figure out how to have them be together.
We've seen the extremes with the hospitals on one end and then the FQHCs on the other, where they have this primarily outpatient-based training program. I got to say, remember Dr. Dan, the the difference with the responses to some of the general questions we'd have with the students or the residents who were in the primarily outpatient-based training versus the ones who were in the hospital. But still, I mean, I think there's only, 150, 160 of these these FQHC-based training, at least family medicine residency training, out of like 1,500 of them. So we still have a long way to go. And many of those classes are still small. Maybe they have 6 residents.
Right. And Wendy, I know you're working at a new innovative medical school that's focused on training physician leaders, right? And you've hit on some of the different, I would say, innovative models of care, and you could have either incremental innovation or disruptive innovation. But what are you hoping to achieve? I mean, what's the important thing for these students to learn about leadership? What's the important part of leadership for the doctors of the future?
Thank you for bringing that up, because I think one of the things, as I've kind of been, really thinking about this work over the last 5 years in a variety of different settings, is that with all those changes in healthcare, I think one of the reasons why we hear physicians, and particularly people in primary care, but I think all physicians, feeling very disheartened and sometimes disengaging, we talk a lot about burnout, is that feeling that people are victims of the system. And I think if we teach people leadership skills as they're learning their clinical skills, and how those two things mesh, and some of those leadership skills will actually make you a better clinician without even thinking about the systems piece. But I do think thinking about how, if we have those leadership skills, knowing about ourselves, knowing about how to work in teams, knowing about how the system works, then you can be agents of change. Then you can feel like you have agency. And this new generation of learners, they're really passionate. They're really impatient. They want the changes to happen now. I have a rising high school senior at home. They want change to happen, yesterday, and they're impatient for all of the rest of us. And that generation of learners is coming through now, and it is exciting. So how do we capture that? How do we capture the social justice, the passion, the impatience, and say, you know what? Your home is family medicine. Your home is primary care. If you want to make the world a better place, as a doctor, this is the best way that you can do that. But I do think learning about leadership skills, no matter what field you go into, is going to have, my theory is it's going to make us more resilient, and it's going to help us more effectively change our healthcare systems from physicians doing it instead of non-physicians. I think that's one of many people's challenges is, we want to have physicians engaged and involved in that.
Going back to when I was a resident back in the dark ages, when the dinosaurs still roamed the earth, there was this, I had more than one attending tell me that you had to do your own blood pressure. You could never trust the nurse's blood pressure. You had to read your own blood pressure. And I remember when I got into practice, I'm like, well, this makes no sense. If they're not doing a good job taking a blood pressure, then that's a problem to solve. We need to work on that together. But if I take time to take 25 people's blood pressure every day, that's taking a lot of bandwidth of time I could be spending on other things. How do we get past that? I mean, the other thing I remember is I remember very clearly getting on the elevator as I think a medical student, and there's one of the chief residents in surgery who obviously hadn't slept, and he was very frustrated about something, and he sort of slammed his hand against the side of the elevator, and he just looked at me and my classmate and said, if you want something done right, you got to do it yourself. And that's part of the mentality that gets us in trouble as physicians, right?
Absolutely. And it's interesting because, as we've been designing, our students start in less than a month. It's very exciting. But as we're thinking about how we build this, a big part of it is, the term we use is interprofessional education. But really, it's about how to work in teams. But how to work in teams by learning about how everybody works together and learning how you're going to better work and better lead teams, because physicians often are leaders of teams, but also how to follow in a team, because sometimes it might be the nurse leading your team, and learning how you function in teams, communicate in teams, so that, when you're asking about the blood pressure, you've learned about closed loop communication and you know how to get that done, right? Just a very concrete skill, but also thinking about the attitudes and about yourself. Are you someone who has a hard time trusting somebody else taking the blood pressure? Okay, I know that about myself, so I need to work on that so that I check myself when I have the instinct that I want to, not just, I have to do it myself, that like, that's not really the functional way of doing things. It's not good for the patients. It's not good for us. It's not good for our teammates.
The role of the newer models, the direct primary care, the more risk practices, I don't know about the resident rotation experiences in direct primary care yet. That's probably something we could reach out to some people who are taking. I know some people who are having that experience, but I remember, at least in our own experience, when we would have the students come through and rotate through, the biggest shocker to them, like I would ask them, what's the difference that you felt, working in a model that's no billing, it's full risk model versus your traditional rotations. And the students would come back and it was a unanimous about the accessibility. Our view, the way we view a patient showing up unscheduled. So I feel like there's a tremendous role for the models outside of the traditional fee-for-service model for the students. But what are some of the roles that you think, I guess we could call them the disruptors or the innovators, have people outside of the traditional model, or maybe people in hybrid models, have for the training of our new doctors?
I think we need to reach out and work together. Again, the medical schools have the expertise. A big push right now in medical education is competency-based medical education. It really is not, those of us on the screen, it's not the same medical school we all went to. And it's for a good thing. And I think it's more inclusive and it's actually really focused on how to get better outcomes for our patients. But, the disruptors don't have that knowledge. So it's a partnership. But the disruptors have this knowledge of different ways of doing things. And it's so funny, right? You don't know what you don't know until you see it. And then you're like, oh, I never thought about the fact that like, if I worked in a practice where I did actually have to take my blood pressure as Dr. Dan, but it was because then we shifted the helpers to the back end. So I didn't have so many things in my inbox, but like, I would never have thought about that before until you see it. Right. And then it's not a reason we can't do that in more traditional models. We need to have the freedom. And sometimes it's easier to do that with a blank sheet of paper than it is with something that's been around for, 30, 50 years. Right. So, but I think we can all learn from each other and our students can learn. And our students can teach us because, one of the great things about medical students is they get to ideally rotate in all different types of settings and be able to learn about how systems work in a lot of different settings. And a lot of medical schools, including, the one we're working on, we're really looking at how to make sure students have opportunities to learn in all different aspects of the healthcare system, that they really experience the entire ecology of healthcare, not just the little box in the corner that is academic medical centers. And honestly, most academic medical centers, we're all in these big systems and we have those opportunities. We just need to get the students out into them.
So I know you work on research as well, right? And that's one of the problems with medical research in this country. Only 3 cents on the research dollar or something goes towards primary care, yet we know that primary care is the only specialty that can improve outcomes and lower cost if we can add more primary care. So it would seem to be working on that effectiveness would make a huge difference. But and I know you do research on the effectiveness of education. So how does that work? How do you? It's great that we're talking about competency-based education, but there's always a question of how do you measure competency? How do you keep from having bias interfere with whether you say somebody's competent or not?
Yeah, so I absolutely. And, a lot of the research in that area came out of, years of being an associate program director and a program director, right? I had to make decisions about what to do with my curriculum. And as someone who is very evidence-based and, wanted to look at the research about how to best care for my patient, I was like, what's the best research about how to, if I want my graduate to be able to deliver babies or to be able to do great value-based care or, really good at quality improvement, what do I do in training to get that outcome? And the evidence doesn't exist. And so it's been exciting getting to work with the American Board of Family Medicine, and other boards are working on this. Other specialty boards are working on this as well, to really think about how do we take what people do in practice and tie it back to their training experiences to better define how, what are those decisions a program director can make to get the outcomes that their community wants. And it's, it takes a long time because you have to measure things and train. Like the study I've been working on looked at the class of 2018. We're still working on getting the papers out, right? Because I had to wait for them to be out in practice to be able to get those outcomes. But we're starting to do that. We're starting to think about that in meaningful ways. And I think trying to be able to better inform, and our new program requirements are trying to use some of that data to inform what those program requirements should look like, to kind of really push us all forward. It's hard, but to try to really push us all forward and think differently.
So what has been your biggest aha from the class of 2018 so far? I mean, and honestly, they've lived through a pretty crazy world, right? I mean, they've lived through the pandemic. So I just wonder what at least your initial ahas from that data
are. So we call the study the Family Medicine Residency Outcomes Project. And so we asked the program directors as they were graduating what happened. And then we waited for the ABFM AFMRD National Graduate Survey to come out for that class. And that was in 2021. They survey everybody 3 years after graduation. If you remember, 2021 was kind of a weird year. So it was, so that was not what I thought was going to happen when I designed the study in 2018. And what we found, interestingly, is particularly for OB and pediatrics, for caring for pregnancy and caring for children, role modeling is super, super important. Seeing faculty do that, in a robust way was important. And having the exposure, particularly for your care of children within your own family medicine practice. So again, it didn't matter how many months of peds rotations, to your point, Dr. Faisel, is like, it doesn't matter how many, being in the hospital and rotating on peds for 5 months. It mattered that you saw kids in your clinic and you saw a lot of them, and for inpatient, it's interesting, for other things, it was a little bit more mixed, but for those two in particular, we really found that role modeling, and having that role model mattered, and having, the right kind of exposures also mattered. But time didn't seem to matter as much. And, and now we're starting to ask residents what they think while they're in training. So that'll be also interesting to see.
Are the students open to the leadership training, like in the curriculum, like actually like with conflict resolution and, just how to effectively lead teams or working with teams? Are they open to that? Or are they more? I remember when we first started doing the value-based care lectures, I remember one of the comments we had was one of the residents said, I'm a resident, not a social worker. Because we were talking about how to overcome some of the, we were talking about motivational interviewing, and I remember I wanted to know, like with the students, is there a resistance with the leadership training piece, or are they open to it?
They haven't arrived yet. 24 days. In 24 days, they will arrive. So I'll get back to you in 6 months, and I can give you an update. But I will say the enthusiasm for wanting the training was huge. We actually had more students accept than we anticipated, because I think that reflects there's a huge desire and need and want from, again, this generation for this kind of training, for this ability to make change and to not wait 20 years, but to do it now. And I think, so I think the desire is there, but I can give you a report in 6 months.
So the real question is, did more students accept than you have seats in your classrooms? And if so, who's going to go to Target and buy the lawn chairs for everybody?
No, we planned for it, and we've got plenty of space. We are well prepared. We are so excited for them to join us in a couple of weeks. It's really, really exciting. But yeah, no, luckily, our system has the capacity for it, which is why, I think, as we think about growing medical schools, we know there's a huge desire for people to go into medicine. We need to think about having them in places that allow people to get the training that they need to get out into the community, and the clerkships, about a quarter of my clerkships are going to be in community-based settings, because, that's where they're going to, that's where the good training is. So I think we're going to, it's exciting to be able to do that and, have more students have more future doctors, in 4 years, there'll be more MDs graduated in Massachusetts. So that's really exciting.
I wonder now, like I think about, what we knew about population health as doctors 15 years, where we are now compared to where we were with population health, and what would happen with the new generation of physicians coming in, understanding the value of this type of data.
What's exciting is we're doing it somewhat in the leadership curriculum, but actually, so we're a regional campus for UMass Chan, and the whole medical school just revamped their entire curriculum. And that's happening, I think, in a lot of medical schools around the country. It's getting to that competency-based medical education. But one of the competencies they're really looking at is this population health, is making sure people understand how to take care of patients, not just episodically, but looking at the impact of health over time. And really thinking about structural determinants of health and how that impacts, and that being weaved throughout everything in the curriculum. So you're not just talking about it in a population health rotation, but you're talking about it on surgery, and you're talking about it on medicine, and you're talking about it, in everything that you're doing. So I think it being really just in the DNA and the fabric of of training is, really exciting to see what this next generation and how they're going to approach things. I think the leadership skills on top of that really is exciting, because they're going to be going into systems that may not be ready for all of that they have for that. And so then having those additional leadership skills to be able to influence positively and effectively, I think, is also really exciting.
I was just thinking, you're talking about, so there's leading laterally, leading your colleagues. There's leading the team that I hate to say below, but maybe in the less intensively trained roles on the healthcare team, right? Without as much education. But then there's also, how do you lead up? How are you going to teach the medical students how to lead up when they finish your program and now they go to a residency program somewhere where the residents haven't had this training? How are you going to teach them how to lead up and influence their leaders and still maintain a good relationship?
Yeah, I think a lot of that comes down to the approach that our team that's really leading this leadership curriculum is really thinking about value-based leadership, and really thinking about leading with your values, and that, and so using that. And I think that approach really helps with that, right? Because if you can come to what are our shared values and how do we move forward with that? And if there is conflict in values, how do you have effective conversations with that? I think is really important, so that you can do that, because I think that's one of the big pieces for all of us is often we find we have the shared values. Sometimes we don't. Okay, if you don't, how do you have that conversation in a respectful, inclusive, and effective way so that you can get to a resolution? And I think, that's kind of some of the pieces that are being worked out for us to be able to work with our students, because I think it's a really valuable skill, particularly in medicine.
We were reading over some of the notes that came over earlier this week, and I wanted to ask you about the ABFM National Resident Survey. What was the purpose of that?
The ABFM National Resident Survey, I'm so excited by this. So again, as a program director, I was like, we're serving all these other people, and the ACGME does survey residents, but you actually, it's a survey for accreditation. It's not a survey for feedback, right? It's a little bit different. And a lot of other specialties were doing this, where they were using these surveys to really, at low stakes, no program's going to get in trouble, no person's going to get in trouble, to be able to really understand what residents are experiencing and seeing in residency. So Lars Peterson and I got together, and with the blessing of the ABFM board, said, let's do one for family medicine. We piloted it last year. It went really well. We're in the process of doing the revisions for 2024. And what I really hope is that any family medicine resident listening to this completes the National Resident Survey at the end of their in-training exam. So you take your in-training exam, and they'll say there's 2 surveys to take at the end. Please complete the survey, because it's so important. The leaders of the specialty are listening to our residents. They want to hear what the residents have to say. And this is a valuable way of getting a huge, we had a 60% response rate last year. We want to get that higher. Other specialties have 80, 90%. That's what we want. We really want to hear what residents are thinking, so that it can influence policymakers. It can influence us as a specialty to make sure that we're meeting resident needs, and we're knowing what the workforce is thinking during the training period. And then we can actually look at how that impacts what happens out in practice because it's part of all the surveys that the American Board of Family Medicine does.
So what you're saying is that I think a lot of times we fill out surveys and we don't think anybody's listening. I know both you and Lars are very detail oriented. So if anybody's listening, if you all are leading this, these voices are being heard and they will be heard widely by the people who are making the decisions about what education is going to look like in the future.
The results from the survey have been discussed in many venues by the leaders. We actually are going to put the summary results up on the website. That's something coming up soon. And they're influencing, a policy brief. So American Board of Family Medicine policy briefs. We've got a few that are going to be coming out, and a few research papers, even just from the first one. So I think this is similar to the National Graduate Survey. I think this is going to be huge for us to really better understand and see the trends that are happening, but also be able to be a little bit more responsive. The National Graduate Survey is 3 years after residency. It's hard to be responsive, whereas, we get this in residency, we can pivot and act much more quickly.
Are there some of the key findings that you can talk about from last year?
One of the things we were very alarmed by is the amount of pajama time residents are doing in residency. That, really they're being acculturated super early to the fact that you work on your ambulatory EMR at night. So, that's something that is in a lot of discussions and we'll be getting more information out on. And that the clerkship year is critical for when people decide when to choose family medicine. That's another one that we've really okay, we knew that kind of, but it's nice to have it confirmed. Right? That, that residents in their first year saying, we ask them, when did you decide on family medicine? And that, the clerkship year is the critical year.
The residents have a huge influence on that. I don't know if that came out of the survey, but at least that was my personal experience, is I was very much influenced by the family medicine residents that's what I wanted to do, because they seem to be happier than the other residents at where I was. At least that does make a big difference. If we want more people going into primary care, then we need to take better care of the faculty and the residents who are teaching those people right now, so that they're not feeling burned out when they're being the influence on the future learners.
Absolutely. And so many medical schools, they don't even, most medical students, I think, are not with residents. They're with people out in practice. So it's so important for people, who are finding joy in practice, right? Well, their medical student is with them, because it's influence. That's what makes the difference to decide the future pipeline.
Thank you so much for joining us today and for this conversation. And that I'm excited for you this next month with the new class coming on board. And we'll have to bring you back next year to talk about your learnings.
Absolutely. And thank you guys so much for all you do to really highlight all the different ways we can be enthusiastic about primary care and think about, the good work that we all do. So thank you for highlighting all that.
What are your thoughts on From Classroom to Clinic, Leadership and Healthcare Innovation? You've heard ours. Now we want to hear yours.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.